Looking at this model of the human nervous system, we can trace the structural hierarchy of physical therapy. Rehabilitation scales vertically, from isolated damage in peripheral nerves of the arm up through the complex central pathways of the spinal cord and brain. Every physical therapy intervention is dictated entirely by accurate anatomical localization. The exact coordinate of a nerve lesion determines whether a patient needs targeted joint mobilization or comprehensive, life-supportive care. The most critical coordinate is the junction between the T12 and L1 vertebrae. This boundary line divides neurological injuries into two clinical presentations. Injuries above that threshold fall into upper motor neuron, or UMN, territory. Damage below lands in lower motor neuron, or LMN, territory. To understand how treatment protocols are built, clinicians must first map localized peripheral nerve assessments, then differentiate between those UMN and LMN lesions, and finally deconstruct the multi-system failures that follow severe central trauma. Mastering this anatomical progression allows a physical therapist to look at a complex systemic physiological failure, like a collapsing respiratory system, and trace it straight back to a single neurological origin point. Before analyzing central disruptions, we establish a baseline by mapping functional anatomy in the extremities. Motor control is highly localized. The quadriceps act as the primary movers for knee extension, while the biceps brachii directly drive elbow flexion. Down in the lower leg, the tibialis anterior is the specific muscle responsible for pulling the foot upward into ankle dorsiflexion. When healthy mechanics fail, clinicians look for specific peripheral nerve impingements. In the upper body, individual nerve lesions create highly predictable mechanical deficits. Damage to the radial nerve, for instance, immediately presents as wrist drop, an inability to actively extend a hand. If a patient presents with carpal tunnel syndrome, the mechanical failure is caused by the direct compression of the median nerve at the wrist. Moving to the head, cranial nerve 7 uniquely governs the muscles responsible for facial expression. We can observe this isolated failure mechanism in the lower body through clinical tests. This animation shows a positive Trendelenburg sign, where a downward drop of the pelvis points directly to weakness in the hip abductor muscles on the opposite side. Tracing a drooping pelvis to weak hip abductors, or wrist drop to a radial nerve lesion, proves a core rule. Identifying an exact biomechanical failure dictates the highly specific, localized mechanical correction required. That localized logic scales up dramatically in cases of spinal cord injury. Acute damage happens when the spinal cord is mechanically compressed, combined with vascular ischemia, a cutoff of blood and oxygen, lasting beyond 15 minutes. Immediately after the trauma, the patient enters spinal shock. This is a temporary neurological blackout effect that completely masks the true extent of the structural lesion, sometimes lasting for weeks. Once that shock subsides, the exact position of the injury reveals itself. Upper motor neuron injuries occur above the T12 and L1 junction, or present chronically after cerebral events like a stroke. Because UMN pathology involves a loss of inhibitory signals from the brain, the spinal reflexes become uncoordinated. This cascades into severe spasticity and hyperreflexia, causing the limbs to move in erratic, jerky patterns. Clinicians confirm a UMN lesion by testing for a positive Babinski sign, a specific reflex response in the foot indicating disruption in central nervous pathways. The severity of this UMN-driven muscle tone dysfunction is then rigorously quantified using the Modified Ashworth Scale, or MNS. In direct contrast, lower motor neuron injuries are located strictly below the T12 and L1 boundary. In an LMN pathology, those spinal reflexes are completely absent. The limbs become entirely flaccid, and spasticity does not occur. Observing severe muscle spasms versus complete flaccidity gives the physical therapist a direct, incontrovertible map to the lesion's vertical position on the spinal axis. Spinal trauma disrupts the body's unconscious autonomic systems, destabilizing the regulation of blood pressure, temperature, and internal organ function. Systemic patient immobility immediately drives deep vascular risks. Without muscle contractions to pump blood back to the heart, circulation stagnates. Preventing deep vein thrombosis becomes mandatory. Medical protocols require daily heparin injections to thin the blood, paired with electrically inflated compression stockings to force circulation. If the spinal injury occurs anywhere above the T12 vertebra, the patient faces imminent respiratory failure. Paralysis of the abdominal muscles and the intercostal muscles between the ribs fatally compromises basic breathing mechanics, often requiring the use of prolonged mechanical ventilation. As the acute phase ends, chronic patients face unique pain pathologies driven by severe mechanical and neurological wear over years of altered movement. Transferring body weight and propelling a wheelchair forces compensatory mechanics onto the upper body, resulting in aggressive mechanical wear and overuse injuries in shoulder joints. We also see secondary neurological threats, like the formation of a syrinx. As shown here, this fluid-filled cyst can develop at the original injury site, expanding longitudinally within the cord to cause new, late-stage losses of motor function and sensation. At this stage, what began as a traumatic orthopedic impact is now a comprehensive, life-threatening internal management crisis. Surviving this crisis requires rigorous prophylactic mechanical offloading. This starts with skin tolerance, the precise, measured time limit flesh can withstand pressure before ischemia and cell death occur. Preventing tissue death requires structured bed positioning. Patients must be rotated through specific alignments, back, side, and prone, to relieve pressure points. But sitting upright introduces a hidden danger: shearing forces. Skin grips the bed sheets while gravity pulls the underlying bones downward, tearing flesh from the inside. Even without pressure sores, unmoving, flaccid, or spastic limbs face the physiological risk of severe contractures, where soft tissues and muscles permanently shorten and lock the joints in place. The primary defense against contractures is strict physical positioning and a daily protocol of passive joint ranging. Therapists use specific bracing interventions, utilizing rigid foot plates to maintain a strict 90-degree ankle alignment, preventing the Achilles tendon from shortening. During passive ranging, there is an absolute safety rule. A joint must never be forced through an active muscle spasm to prevent internal tearing of ligaments and tendons. Prophylactic biomechanics serve as primary, life-saving interventions. In a failing biological system, the survival of the patient depends on the rigorous maintenance of joint mobility and skin integrity. Following this flowchart, clinical interventions anchor an exact neurological assessment. Diagnostics drive the strategy. Hard data dictates isolated modalities, applying ultrasound for deep heating or TENS for localized pain relief. For functional stability, closed kinetic chain exercises, like squats, force multiple joints to bear weight. And when active movement is neurologically impossible, the protocol shifts entirely to preservation, deploying continuous passive motion devices to artificially move limbs, maintaining joint integrity. In neuromuscular pathology, rehabilitation demands the rigorous, lifelong mechanical management of a biologically compromised system.